Hello, and welcome to this special edition of the Lipid Insights podcast brought to you by the National Lipid Association. My name is Dr. Peter H. Jones, and I'm going to be your host today. And what we're making special about this podcast is that we're celebrating National Lipid Day, and that's May 10th. So yeah, there are a lot of special days throughout the year for people, organizations, and groups, but I'm just so excited that there's one that means so much to me over my career, National Lipid Day. So I've spent the last 4 decades dealing with lipids as a clinical lipidologist and dealing in preventive cardiology. So it's wonderful that I get to host this podcast. And even more impressive is I get to host this podcast with the amazing Dr. Tom Dayspring. And he has been a friend of mine for a long time. And Tom, welcome.
Well, it's a great pleasure here. And I, again, appreciate the National Lipid Association putting us together, Peter. We do go way back, as you said.
Yeah, we do. And listen, on this discussion today, we're going to be dealing with a lot of topics that I think most of you would love to hear from Dr. Dayspring. You've probably heard him speak before, and I know you've heard him do his little discussions on LinkedIn, where he is known as the Lipid Doctor, and you've probably even seen his more amazing graphics that he puts out on LinkedIn, which are just the most beautiful graphics about lipids and lipoproteins. And so I hope you follow him there. And also just recently, Tom was given the honor of master in the National Lipid Association. And so congratulations and welcome to the club, Tom, on that one. That was a great honor. So Tom, I'm going to turn it over to you. I'm not going to read your 10-page CV. I'd like you to sort of tell everybody what you're doing and what interests you have had over your career.
Yeah, like you, Peter, I've sort of been chasing lipids for 4 decades, and I go way back. I'm more of a dinosaur even than you, a little bit anyway. I went to college in 1964-68 at Rutgers in my home state of New Jersey, and did pre-med. But I like to point out that my 2 favorite subjects in college, and actually I had enough credits. I got majors in botany, zoology, and chemistry, but my 2 favorite courses were organic chemistry and biochemistry. Of course, then you go over to med school, and first year you get more biochemistry, and I enjoyed it in med school too. But we had to do a term paper in our biochemistry, and for whatever reason, the professor assigned me, Dayspring, write a paper on A-beta lipoproteinemia. I don't even think I knew what a lipoprotein was at that time or anything. So I had to do a little bit of research to find out what the heck is that. And I always joke, I don't know, that must have set off circuits in my brain that lipids are what you're going to ultimately do. So went through med school, of course, and wound up in a residency in internal medicine. And that was 72, I did that. And at that time, what was really exciting in the world was the development of coronary angiography. Invasive was the big thing that was being done. And of course, coronary bypass surgery was the result if something was wrong with your angiogram. But the other thing was the development of coronary care units, which was a new concept. And like if you were a young resident, the cool place to hang out was in the coronary care unit or tag along with a cardiologist and watch these people getting tubes stuck in their heart and die injected. So I just fell in love with cardiology. I knew I was never going to be a cardiology because after 3 years of internal medicine, I wanted to go out and make a living, not do more time learning how to stick those things in people. But the other thing, what was going on in Peter, it was a fun time to be a resident because if you were on call every night, you had 2 or 3 acute coronary syndromes, fulminant pulmonary edema. And our treatment was, if they survived the CPR, was bed rest and oxygen, inappropriate antiarrhythmic therapy, which we didn't know at the time was inappropriate, and maybe some heparin. That was it. And bed rest for like 3 weeks. and then send them home if they didn't have a pulmonary embolism. So that was fun when you were a resident, but once you go into private practice, it was not fun getting up at 2, 3 o'clock in the morning and having to drive back to the hospital to help some poor patient who had that. So deep in my mind, I thought, I've got to prevent this disease. And at the time, the only thing we could really offer was hypertension control with drugs that have long since disappeared, reserpine, aldamet, hydralazine, things like that. But there was no lipids. We didn't know anything about lipids. The lab was telling us if you had a total cholesterol under 300, 350, you were okay. So we didn't have a concept of FH very much back then. And even if we did, there was nothing you could do about it other than some primitive drugs, which intolerable, very high dose niacin or the fibrates, clofibrate that was around at that time. So I knew in the 1980s, lipids started to develop. We had the Lipid Research Clinic published showing cholestyramine reduces heart attacks by lowering LDL cholesterol. And Friedewald had developed that equation that we actually could get an LDL-C metric. So I just became super aggressive with lipids. But there wasn't a lot. There was no MNLA at that time. There were no colleagues like you I could network with and learn. Yeah, it was all self-study. And start reading journals. I couldn't even understand half of the stuff these clinical chemists were talking about. But long story short, I obviously mastered lipids a little bit. And the big event, I think, that really set off my career was the development of statins. The first one came on the market in 1987. And at that time, pharma decided, oh boy, we're going to invest money in a lot of education. And I had the opportunity, therefore, just because probably reps who were visiting my office said, he knows a lot about lipids. And I got a chance to speak, and the rest is history. My career ended with 4,000 talks in all 50 states, several countries, and most important, begin to meet colleagues like yourself and the other MNLAs and the researchers that I became friendly with. But I think you hinted at what really made my career was when PowerPoint was developed. I somehow learned to master that and start illustrating lipids. And my good friend Mike Davidson early on says, Tom, people learn a lot more visually than they do by listening to words or reading paragraphs or textbooks. So that made my career. Not only could I illustrate lipids, I learned how to make them move and bounce around so you could see where the particles were going and everything. So, and that made my career. And I guess I obviously have a way of speaking that people likes in addition to my illustrations, because I kept being asked back to do more and more presentations. So that's my story in a nutshell. I'm an internist. I'm a fellow of the American College of Physicians. It's a little higher ranking of the internists. And then in the MNLA, when certification came around, I was in the early class that was the first people certified in lipidology. I think I was in the first group when the MNLA started the fellowship of the National Lipid Association. And I've been dormant ever since until I got this wonderful email a couple of days ago that, Tom, you're now an MNLA, a master of the National Lipid. And I went on and saw who's in this. And of course, I see names like yourself and just other people. I can't even believe I can be mentioned in the same breath with most of them that are up there. But so here we are. That's me, Peter. Just an internist who liked lipids.
That is awesome. And what a way to celebrate National Lipid Day with someone like you. So let me start out by getting to the 2026 AHA-ACC Multi-Society Guidelines for the Management of Dyslipidemia, where, thank goodness, they brought back lipids, LDL cholesterol, non-HDL cholesterol, for us to target with our therapies for the prevention of atherosclerotic cardiovascular disease and return of goals of that therapy in patients at risk. So what are your thoughts about that?
No, I mean, there's always going to be things I quibble about, you know that. But overall, I think this guideline was a tremendous advancement and really brought lipids back into the real world. And great credit to all of the people who contributed to that. And I think the biggest thing is they did finally said, hey, there are goals of therapy when you start to treat something, because they had disappeared for a while. Just use this drug and goodbye. You don't have to ever check anything again.
Fire and forget, yeah.
Yes, now we have specific goals. Most people are going to read the short segments of it or the great graphics that tell you how to get through it. But I think anybody who's really interested in lipids, download the whole guideline and read it in its entirety. And there's so much to learn about it. We're going to talk about ApoB. ApoB is not on the forefront of it, but there's tremendous discussions of why ApoB is so important in that guideline. So I think it's wonderful. And the other thing, their new risk tool looks at far more risk factors that we can ascertain what your cardiovascular risk is, and they incorporated things that really were never put in there before. And so we have a better risk assessment tool in two things. They did a 10-year risk assessment and they did a 30-year risk assessment. And that's most important because, we're all young, but we do get old. And if I'm 30, it's nice to know I'm not going to have a heart attack in the next 10 years, but I might also be interested, how about the next 30 years or beyond that? Even if I'm 60. Now, look, 60, that was me 20 years ago. I'm 80 now, and I would love to know, can I go to 100? So that'd be a 20 more. So that was a great advancement. The last thing, they put emphasis on not only is lower is better, and they did give us lower targets, but longer is better. They're very, and they put this, I think it's called a borderline risk category, where if you're a 20-year-old and the equation says you're in that borderline risk category, you have to have a good discussion with a competent physician or a clinician who understands lipids, because there are many people in their second, third decade who have criteria that, here's the lifestyle you have to be on. Let's get on it and see what happens. But you may qualify for pharmacotherapy. And that's a discussion that has to be had, I believe, much earlier in life than it always has been. Why wait till they're 60 and 70? In my day, did you survive the CPR? Okay, let's see what we can do for you.
Exactly. Yeah. Well, my next, this leads up to my next discussion. While it was great to have routine lipid measurements that we get on lab tests, which is an LDL cholesterol and non-HDL cholesterol, but that really isn't telling us about the most important thing, which is in your area, and you're Mr. ApoB, but it's all about atherogenicity as ApoB containing lipoproteins. So what about the guidelines and their recommendation about how to use and when to use ApoB in our assessments?
Now, first, I have to correct you. It's Alan Schneiderman who is Dr. ApoB. I'm one of his disciples, so maybe I'm tier 2 of the ApoB folks in the world. But yes, we know, look, cholesterol, triglycerides are lipids, they're oils. They are not miscible in plasma, which is water. So evolution had to develop lipid-carrying dump trucks that are soluble in water and can traverse the plasma and go where they have to go. And that was very easy. They simply took these oil droplets full of cholesterol, triglycerides, other lipids, and wrapped them with structural proteins, which provided the solubility and the structure to these little dump trucks that carry cholesterol wherever it's going. So, there's two families of lipoproteins to do this very quickly. There's a family that is enwrapped with a single peptide called apolipoprotein B. It's a very big protein with a high molecular weight. And then there's another family of lipoproteins that are much, much smaller, and their structural protein is apoprotein capital A1 or A-1, and those are our HDL particles. And they're all carrying lipids, and it's the ApoB particles that have the potential to leave plasma, pass through an arterial wall layer, the endothelium, enter the artery wall where they get trapped, and white blood cells come in, gobble them up, and before you know it, they're full of cholesterol, and you get a zillion of them stuck together. You have the plaque. We call them foam cells. And the HDLs don't have that. HDLs can go in and out of the artery wall, but they just don't get trapped and contribute cholesterol to the plaque. So it is the ApoB family of lipoproteins. For those who own an ultracentrifuge, the ApoB family is separated into very low density lipoproteins. That means they float on top of the centrifuge tube after they've been spun. We have the low density lipoproteins that sink a little further. And at the bottom of the tube is the high density lipoproteins. What really determines buoyancy is the lipid mass. So the more lipids you carry, you float in a centrifuge tube. HDLs are the smallest particles. They carry the fewest lipid molecules. That's why they're called high density, because they sink in the tube. LDL is in between. So the VLDLs in the LDLs are the basic ApoB members of the ApoB family. And they are the ones that everybody says they're the atherogenic particles. I say they're potentially atherogenic. If they enter the artery wall, they're atherogenic. But right. If they get cleared back at the liver, they're not atherogenic. They're doing what they're supposed to be doing. But it boils down to, with plasma residence time, once they're produced and enter plasma, how long do these particles float around before they're cleared or catabolized? And the LDLs have a much longer plasma residence time than do the VLDLs. VLDLs are, for the most part, a postprandial and after eating lipoprotein. They're the triglyceride-carrying dump truck. That's why they're so big. And they get catabolized. The word in lipidology is lipolysis, or their triglycerides are hydrolyzed. And as they lose the trigs, they shrink. And VLDLs can become an in-between particle called a VLDL remnant, or ultimately an LDL particle, or they can just be cleared by the liver and they don't develop into an LDL particle. But the VLDL's plasma residence time is a few hours for the most part, 4 or 6 hours. So if I measure total ApoB, because there is one ApoB peptide on every VLDL and IDL, I'm getting VLDL-P plus LDL-P. VLDL particle number plus LDL particle number. But because of plasma residence time, in most people, LDLs make up about 95% of the ApoB particles. So you can make the case that if you're measuring ApoB, it's basically an LDL particle count. There are other methodologies that we could get that number with, but ApoB is easy. Almost every lab is doing it nowadays. It's the most affordable of all the, if you want to call it an advanced test. I don't call it advanced test anymore. So it's your ApoB particles. It's particle number that drives them into the artery wall with the LDLs. So once your ApoB, your LDL particle concentration, crosses a certain threshold, some of them are going to be going in. That means your liver, which clears the LDLs via something called an LDL receptor. There's just more particles than you have LDL receptors, so you get an excess particle number, they go in. VLDLs are an ApoB particle too, and there are other things that drive them into the artery wall. They're even receptors and things, but they can get in. And I don't want to offend, VLDLs are starting to take center stage again, the remnants. And I get into arguments because, VLDL particles are far more atherogenic particle for particle than an LDL, of course, because it carries thousands of more cholesterol molecules per particle than does an LDL. Jim Opvos, the NMR guy, always taught me the volume of a spear, the volume of a lipoprotein is a third power of the radius. So, yes, if a VLDL goes into your artery wall, it could dump 5,000 to 7,000 molecules of cholesterol. If an LDL goes in, it can dump 1,500, 2,000, whatever is in that particular LDL particle. But because of the plasma residence time, the overwhelming vast majority of ApoB particles are LDLs. So to my VLDL friends, I'm with you. I don't want remnants. I know how to diagnose them and take care of them, but never forget it. Don't forget LDL particles is really what drives ApoB.
Absolutely. Well, if clinicians want to measure ApoB, maybe some want to do it all the time. Can you get it with LabCorp and Quest, or do you have to have some sort of special testing thing to get it?
No, it's available. It's a simple assay. It's done on the same platform that your chemistry profile is done on or so. So it's easily done, easily reported. More coverage is far better than it used to be. So there's no reason, don't ever say I can't get it because this is such a rare lab test. And the sad thing, Peter, is we've been so LDL-C focused for a long time, appropriately so. but people have not been trained on ApoB. A lot of practicing clinicians are even cardiologists are unaware of what ApoB is and why it might be a better marker of atherogenic risk than is LDL cholesterol. And this is why I wanted people to read the whole guidelines, because they get into all of that. They haven't made ApoB the main goal of therapy. I think in the future it will be, but we're going to have to train more people what ApoB is. And even the lay public has been preached to about LDL cholesterol. If we came out tomorrow and said, forget LDL cholesterol, just get ApoB, oh boy, that would create mass confusion.
Yeah, I tend to agree with that. There is one ApoB that's not atherogenic. It's called ApoB 48. That's on chylomicrons, right?
It is. So the ApoB peptide is made in the liver, the one I was talking about. So it has a molecular weight, I believe, of 550 kilodaltons. So it's a big peptide. So the intestine also makes an ApoB particle. Peter named it. It's the chylomicron. And it's actually much bigger than the VLDL particles. So they actually float in a centrifuge tube. They don't sink at all, if that's your methodology of investigating these things. But they're so big because the intestine packs them full of whatever cholesterol has been absorbed, but also the fatty acids that have been changed into triglycerides are put in the chylos. They have a circuitous route to get into plasma. They leave the enterocytes, the intestinal cells, travel through the lymphatic circulation, and enter the plasma up in the thoracic duct in your neck where lymphatics empty into the plasma. So you have these gigantic triglyceride fat balls, but they had to be wrapped with a structural protein. And the intestine was gifted the genes that makes what we call a truncated ApoB particle compared to the liver. So nomenclature, the liver is called ApoB 100. It has 100% of that molecular weight of 550. The truncated version that the enterocytes make have 48% of the molecular weight of the hepatic produced ApoB. So it's called ApoB 48. It always confused me. I would think chylomicrons would need like an ApoB 200, because they're so big. But I think just having the ApoB 48 obviously makes them soluble, and it gives them more area to expand. They're not constricted by the big ApoB 100, I believe. And so they enter plasma. They deliver their triglycerides very quickly to adipocytes or muscle cells, and they're rapidly cleared by a specific receptor in the liver. So their plasma residence time is really a couple of hours at most. Their actual half-life is like 5 to 7 minutes, particle for particle, but they'll be around for a couple hours after a meal. And they are really, if you're doing triglycerides every hour after a meal, for the first couple hours, it's chylomicrons that are driving that triglyceride level. And then the VLDLs, which don't get undergo lipolysis as quickly for certain reasons, then they get catabolized and then they disappeared over the next 2, 3, 4 hours. So that's the ApoB 48. It's the little ApoB produced in the intestine. But the last thing I should say is because chylomicrons come and go so quickly, and they're important because of their volume, they're massive, but there aren't very many of them. So they don't contribute to an ApoB level when you do it. First of all, if you're doing fasting, they don't exist. They're a postprandial pour. But if you did a postprandial ApoB, the chylos really don't contribute to it. Their particle number is so small. Not that they can't be atherogenic. They turn into these remnants also, but it's not driven by particle number. By the way, the assay, when you do ApoB assay at LabCorp, Quest, or any other lab, it includes ApoB 48 plus ApoB 100. Oh, okay. But 48 just doesn't contribute to it. I get emails, Tom, where can I get a chylomicron particle count? I said, I have no idea, but you don't need it.
Yeah, I agree. Well, speaking of ApoB containing lipoproteins, and the vast majority of them tend to be LDL particles. But in some people, genetically, they get another ApoB lipoprotein with a little a on it as well. So lipoprotein little a, tell us where we are with that now.
Yeah, so we're still in the ApoB family here. And I said, hey, it consists of VLDLs and LDLs. But some people who inherit a gene that turns their liver protein producing apparatus, the endoplasmic reticulum. It tells them, make another protein called ApoB, and it's been subsequently named apoprotein little a. And so within the liver cell, when that's produced, it can swim over and jump on a primordial LDL particle that the liver is producing. And if I stick apoprotein little a onto an ApoB 100 containing LDL, it adheres to the ApoB particle by a bond. And so when that particle gets secreted into plasma, it's an LDL, an ApoB particle that's got somebody who else jumped on it, and that's apoprotein little a. So that particle is called lipoprotein little a. And we know from all sorts of studies, it's really a bad news LDL particle. So
it
essence
gets
what it is.
It is. I mean, it definitely contributes to atherogenesis as well as calcific aortic stenosis. But interestingly, genetically, maybe 1 in 5 people end up having really high LP little a's, and that's determined by the length of the Kringle 4-2 repeats in the apolipoprotein little a thing. So, you have to measure LP little a to figure out whether they happen to have inherited that tendency, because that's a lifelong risk if they inherit that Kringle 4-2 repeat. So I guess in the new guidelines, as well as the MNLA is recommended, that everybody get at least one LP little a measurement in their life, right? And then if it's low or normal, they don't need to have it measured again. Is that correct?
That is correct. So you either inherited the ability to produce apoprotein little a or you do not. It came from mom, it came from dad. If you're unlucky, they both had it and passed on the genes to you. But if you have a mom or dad who don't have the genes that produce apoprotein little a, you will not have it. But the terrifying thing is, and Peter gave you that number there, basically 20% of the humans walking the planet Earth have a very elevated lipoprotein little a. It is by far the single most genetic abnormality that is associated with atherogenesis. And Peter did drop in that in some people, it can invade the aortic valve leaflets and cause calcium deposits and narrowing or stenosis, as we call it. It's a pretty becoming a common cause of aortic stenosis. In the past, nobody even thought of checking LP little a if you had aortic stenosis. And now it's hopefully being done routinely. So, oh my God, no wonder. But this is another reason why the MNLA and the European Atherosclerosis Society wants LP little a to be done once in your life, preferably, I think, early in life. Look, the pediatric guidelines, even the new MNLA guidelines suggest that, look, if you're a little baby and mom or dad has homozygous FH, get your lipid panel at age 2. If you don't have that type of parent, thank God most don't, get a lipid profile around the age of 8 or 9 or 10. And then if you're clear there, you don't have familial lipid disorders, then you start doing it again regularly when you hit age 19 or 20. And if you're clean, every 5 years, if you're abnormal, more frequently. But they didn't tell you exactly when to do LP little a, except, hey, in adults, probably when you're age 19. But look, if you're a 9-year-old kid going in and mom and dad want you to have a lipid panel, I see no harm in checking their LP little a. It's just a blood test.
Right.
People say, well, we don't know how to treat it in kids. I think we do. It's the same way we treat adults now. We put them on good lifestyle. If, God forbid, they do have FH, we treat that with drugs in kids nowadays. Right. So once in your life. But if you have it, right now, there's really no need to repeat it because we don't have a specific therapy that lowers it. We don't even know, is there a goal of therapy if you have high LP little a? How much do you have to drop it? We will know that information, I think, pretty soon because there are investigational drugs in trials that dramatically reduce LP little a. And I think we'll get information out of that, hey, you got to make it 0 or you only have to drop it 40%, 50%. So we'll get a little smarter on that soon. But once in your life, and the last thing I'll say about that, if you're of the 20% who has it, and by the way, Asians have a higher incidence and African Americans even higher, then you tell mom, dad, if they're still around, brothers and sisters, if you have children, please go get your Lp(a) tested, because it's a silent killer. Why wait for the heart attack or your aortic valve needs to be replaced and say, oh, yeah, you had Lp(a).
Yeah.
You've got to check it nowadays.
Yeah,
every lab does that too.
It's easy to do. Yeah, it comes in nanomoles per liter. Hopefully, that's where we're headed in the measurement rather than milligrams per deciliter. You think that's going to end up being the universal measurement?
It is. Certainly, the guidelines recommend it, and laboratories are starting to jump on board with that too. Right now, some labs will report it as a mass measurement, milligrams per deciliter. That's basically all of the lipids that are being carried and everything that's in an Lp(a) particle. It's basically weighed. And, there are studies that show you at what level mass measurements become worrisome. But it's just like LDL particles, it's particle number that matters. And they're reported in molar concentration. That's what moles is. Moles tell you the number of whatever you're measuring yourself. So the metric you need is not Lp(a) mass. It's Lp(a)-P, particle count. And one complexity is they're still working on a super standardized test for Lp(a). That's a little bit of the issue with measuring it and or not. But that'll be solved soon, and we'll have standardization of that.
All right. Well, one other lipoprotein we need to get to, and you mentioned it at the beginning, is HDL cholesterol. And, I think there's been a lot of discussion about, and I remember in my career that we always thought HDL was the good cholesterol. It was the one that didn't get trapped in the artery wall. It was the cholesterol that was being pulled away from the artery wall. It was being taken away from cells and delivered back to the liver. So this HDL was a scavenger, and it was a good thing to take cholesterol away. And so we were all focused on okay, you don't need to worry about the HDL. It's good. It's a good level. But I think we've sort of come to know that HDL isn't necessarily good. Yes, you need it, but don't rely on HDL to make decisions about how you're going to treat patients or focus on it. So what's your feeling about where we are with HDL now?
Well, we know a lot, a real lot, but I still think we're in our infancy on truly understanding all of the things that the good Lord gave us HDL particles to do and everything. So, and our part of the difficulty was the only way we've ever measured something about HDLs was to measure the mass of cholesterol that they're carrying per deciliter or per liter if you're using moles, millimoles or so. And the early studies, which are all epidemiologic, Mr. Phipp, Framingham, going way back to the several studies, all suggested that, wow, we're noticing that there's a higher risk of atherosclerotic events in people who have low HDL cholesterol. And we don't see as many events if the people have normal or even higher levels of HDL cholesterol. Hence, epidemiologically, it sort of made sense. That's the good cholesterol, because they also correlated that the amount of cholesterol in LDLs was a big risk factor. So obviously that's the bad cholesterol. Well, here's the darn truth. HDLs, I told you, are an ApoA1 particle. They're not an ApoB particle. The liver secretes ApoA1. The intestine makes a little bit, and it sticks to the chylomicrons for a while and then is released when they undergo shrinkage. So ApoA1, once it's secreted by the liver or freed from a chylomicron, is like a little peptide that swims around, but it rapidly adheres to any cell that is trying to get rid of excess cholesterol. And I like to point out to people that cholesterol is absolutely needed for health. There'd be no humans without cholesterol. Every cell needs X amount of cholesterol. So evolution engineered all cells, gave them the ability to produce all the cholesterol they're ever going to need. But sometimes they produce too much cholesterol. Cholesterol has the ability to crystallize and become very toxic, and it will kill a cell. So evolution fortunately gave cells a mechanism to, oh boy, if you have too much cholesterol, efflux it out through this membrane transporter. We call them ATP binding cassette transporters A1, ABCA1. So free cholesterol leaves the cell And guess what it jumps on? ApoA1, which is floating around. It's a cholesterol acceptor peptide. It's structurally engineered to accept cholesterol molecules. And it keeps doing that. It has the ability to stick a fatty acid on the cholesterol molecule, creating something we call cholesterol ester, which sort of moves away from laying on the ApoA1, and it starts to make these HDLs become first discoidal, elliptical, and finally big fat spears. Nowhere near as big as LDLs, but they're cholesterol-laden particles carrying a lot of cholesterol ester and still some free cholesterol. They also, as they expand, they acquire more ApoA1. And the average HDL particle probably has about 3 copies of ApoA1. Some have more, a few have less. That's why ApoA1 is not as good a particle metric as ApoB, where there's only 1 per particle. So you shouldn't use ApoA1 to really count HDL particles. If you want to do that, there are other methodologies that will do that more accurately. So the HDL is full of this cholesterol now. But I told you, it will accept that cholesterol from any place that wants to get rid of cholesterol. So if a little HDL goes into the artery wall and it butts up against these foam cells that I previously described, it can accept cholesterol out of the foam cell in the artery. Dan Rader, years ago, he gave a name to an HDL pulling cholesterol out of plaque. It's macrophage reverse cholesterol transport. And the HDL takes that cholesterol and it jumps back into the plasma, and I'll tell you where it's going in a moment. Dan also pointed out, as good as that is, and that is good because it's one way to ultimately start shrinking your plaque, the amount of cholesterol pulled out of plaque by HDLs does not contribute to your HDL cholesterol level. It's crucially important, but it doesn't affect what we're measuring. So we have to stop saying, oh, your HDL cholesterol is high, you're sucking cholesterol out of your artery wall. That there's no correlation. And you could have high HDL cholesterol, you don't have plaque. You could have high HDL cholesterol, and you still have plaque. So HDL, that little aspect I talked about is one small part of what we now call HDL functionality. If your HDLs have the ability to leave plasma into the artery wall, and if you have plaque and it delipidates it, that is a wonderful function. But there are probably 100 other things HDLs do that we don't know and cannot measure. You see, HDLs, especially the really small ones, not carrying lipids, carry proteins. Over 200 proteins have been described in the literature as potentially attaching to HDL. Now, that doesn't mean a little HDL carries 200 proteins. You have several small families of HDLs, and this family will carry those 1 or 2 proteins. This family will carry, and each of those proteins has a different ability to do many things in the body. Dan calls it HDLs are a part of the innate immune system. They can traffic proteins to areas of inflammation, infection, whatever, cancer cells, and maybe those proteins will do good things to those cells. But tragically, we now know sometimes these proteins are not there or they're corrupted, and the HDL therefore is labeled as dysfunctional. And Peter knows, and don't we wish we could send you to the lab tomorrow and not only get, I don't care about your HDL cholesterol, maybe an HDL particle count, okay, but I would love to know whether you had functional or dysfunctional HDLs. Only then can I make a proclamation about, this is why the HDL metric we need. Since we don't have those metrics, we no longer rely on HDL cholesterol. Look, it's definitely a marker, an independent marker of cardiovascular risk. If I see your lipid panel and I see low HDL cholesterol, I know you're at risk, but I know there are people with high HDL cholesterol who also can get coronary disease, and other pathologies have been described with high HDL cholesterol. Alcohol is a big contributor to some of the high HDL's cholesterol metrics. So it's just so complicated. And since we can't really measure what matters, HDL functionality, HDL-C has pretty much left the guidelines as any big discussion as to doing it. And I like to point out this, the most common reason that people have low HDL cholesterol is the mature HDL particles are not carrying as much cholesterol as they should. Obviously, that would lower H. What are they carrying instead? Triglycerides, which HDLs were not engineered to carry. Triglycerides take up more space in a particle. They're bigger molecules than is cholesterol. So if your HDL triglyceride level is high, which we don't measure, your HDL cholesterol will be low. And so where do you see high triglycerides, low HDL cholesterol? In insulin-resistant people, pre-diabetics and diabetics. So low HDL cholesterol is maybe a poor man's signal of insulin resistance going on or so. And here's what I tell you. Okay, trigs are up. That is definitely an inducer of ApoB. So if you see a low HDL cholesterol, this is where ApoB can really save you. Your LDL cholesterol might look good, but your HDL cholesterol is low, your trigs are a little bit high, you have cholesterol deficient HDLs, your ApoB is through the roof. And this is why, if you have low HDL cholesterol, the goals of therapy are not HDL cholesterol, what you're doing to it, it's what you're doing to LDL cholesterol and non-HDL cholesterol, or better yet, ApoB. So
exactly. Yeah,
I think everybody understands that.
I think that's one of the points about ApoB. If you're going to measure it routinely, you should in people where you have a discordance between LDL cholesterol and non-HDL cholesterol. And that's meaning you've got probably more ApoB than you think. And those patients tend to have low HDL as well. And that's why there's that discordance between LDL and non-HDL cholesterol. So yeah, that's a fabulous discussion. Now, another thing that you've gotten into here recently and also relates a little bit to HDL is about the central nervous system and cholesterol handling. Now, some people have said, oh, you can't treat LDL too low because that's going to affect the brain, and the CNS needs cholesterol, and low LDL will hurt your brain. Well, actually, it's not the LDL; it's something else that regulates cholesterol within the central nervous system. Tell us about that.
Very complicated. And a few years ago, I heard Dan Rader on a podcast, and somebody asked him, where is lipidology going? Like, what's next? And Dan says it's understanding brain cholesterol is the next frontier of lipidology. So I was lucky enough to meet and tag team with a couple of real, what they call themselves, preventive neurologists who deal with dementia and chronic brain disease. And they were starting to be interested in lipids in the brain, but neurologists are taught nothing about lipids, so they needed some basic lipid education. So if you ask people, where is most of the cholesterol in the body? Where is it made? Everybody answers the liver. Wrong. Actually, most of the cholesterol in the body is made if you summed up all of the peripheral cells together, peripheral cell being anything not in the brain. But if you want to go organ by organ, what's the most cholesterol dense organ in the body? It's not the liver, it's the brain. What is the brain? It's full of a bazillion cells that all have cell membranes. And the real function of cholesterol in the body is, number one, to contribute to cell wall normalcy. If you have normally constructed cell walls, you'll have great signaling. Those cells will be healthy. But if you start screwing up with the amount of cholesterol in the cell walls or their partner lipid, phospholipids there, you're going to have improper cell membranes, and that leads to a lot of cellular pathology. So evolution knew this, that the brain is the most cholesterol-rich organ in the body. So actually, the brain starts getting its own cholesterol while we're still in utero, in the second or third trimester. The first trimester, it's mom supplying whatever cholesterol the little fetus needs. But in the second and third, as the little person keeps growing, their brain starts developing within utero. And of course, the day you're born, then you're on your own. Mom isn't contributing anymore. So it almost takes about 10 years for the brain to manufacture and synthesize all of the cholesterol it's going to need through adulthood. By that age, your brain is pretty much adult size. Now, from birth to age 10, every cell in your body, in the brain, is making cholesterol like there's no tomorrow. Now, there's only a few cells in the brain. Neurons, King taught you need neurons to do everything. But there's another cell. Everything not a neuron is called a glial cell. So astrocytes is one glial cell. Oligodendrocytes is another, and there's one called microglial cells. They are sort of the immune cells in the brain. But early in life, they're all generating cholesterol. Now, the oligodendrocytes make it because cholesterol is necessary to synthesize myelin, which coats all of the nerve endings throughout your body and everything. Once you hit age 10, the neuron says, listen, I'm not going to keep making cholesterol. And you want to know why? Peter, you know the cholesterol synthesis pathway is quite complex. It's 37 steps, plus or minus a couple, depending on how your cells are doing it. It takes over 30 molecules of ATP to generate one cholesterol molecule. So the neuron needs as much ATP as it can get to fire off all its synapses. So the neuron doesn't want to waste ATP synthesizing cholesterol. So after age of 10, the astrocytes were told, you're in charge now with making all the cholesterol that the neuron is going to need. Now, where do these brain cells exist in the body? They're all in something called the matrosome, which is the brain interstitial tissue. So in the interstitial tissue, you'll see astrocytes, oligodendrocytes, microgliocytes, and you'll see the neurons. So if the neuron isn't going to make cholesterol and the astrocyte is, how is the astrocyte going to get that cholesterol over to the neuron? Well, the same way it's traversed in the blood, you're going to have to construct a lipoprotein that can carry cholesterol out of the astrocyte and let it swim over. It doesn't have to go very far and jump into the neuron can then internalize it or delipidate that particle. And here's what Peter was intimidating about. So the lipoprotein that the astrocytes construct, hey, it's a bunch of cholesterol, some cholesterol ester, but it has to be enwrapped with a protein. Now, the brain cells do not have the ability to make apolipoprotein B. It's too darn big. That's probably why. So it had to make a protein that would enwrap a lipoprotein that's being constructed in the astrocyte. And it's called apolipoprotein E, capital E. And the astrocyte makes ApoE, and it either binds to cholesterol ester in the astrocyte and gets secreted, or ApoE is secreted into the matrosome, and it binds to ABCA1, which the astrocyte can. And all of a sudden, you're developing a more mature ApoE-containing particle. And if you stuck it in a centrifuge, it would have the buoyancy or density of a plasma HDL particle. So they're called brain HDLs, but there's a big difference. Plasma HDLs, for the most part, ApoA1 is their structural apoprotein. The brain HDL particles are ApoE particles. So they swim over and they bump into the neuron. Guess what the neuron expresses? LDL receptors, LDL receptor-related proteins, scavenger receptor B1, all of which have the ability to recognize ApoE, and the LDL receptor LRP internalize that particle into the neuron, in essence delivering cholesterol, or the scavenger receptor delipidates the cholesterol, and it's another supply for the neuron. So it's brain creating its own lipoprotein system. And to wrap this up, why you do not have to worry about your LDL cholesterol as affecting your brain, there's something that separates the brain from the plasma. It's called the blood-brain barrier. And the ApoB particles are way too big. They cannot leave plasma, enter the brain, and say, hey, here's your cholesterol. Nope. So the brain has to make all its own cholesterol. There is zero interaction with the pool of cholesterol in your brain and the pool of cholesterol floating in your plasma lipoproteins. We've got 52 studies or more that if we lower ApoB, lower LDL cholesterol, we reduce MACE, major adverse cardiovascular events. We have 0 studies that if you lower ApoB with lifestyle or FDA-approved drugs, that there's any injury to the brain. And this has been looked at most prominently in our most powerful ApoB-lowering drugs, the PCSK9 inhibitors. They can make your LDL cholesterol 10 or 15, especially if combined with other lipid-modulating drugs. And they've taken those people and they've done cognitive studies, and they see no signal of anything going wrong. So you cannot hurt yourself. your brain by therapeutically getting rid of plasma ApoB containing lipoproteins. So important to know. But to put my finishing tale on this complex story, and I often tweet about this or put it on LinkedIn with some nice graphics. I told you the ApoB particles cannot cross the blood-brain barrier, but we now know ApoA1, or the really small discoidal HDLs, if they bump into the blood-brain barrier, there's a receptor there. They believe it's this scavenger receptor again that pulls them in. So all of a sudden, you have ApoA1 HDLs or ApoA1 itself entering the matrosome. And the ApoA1 can swim over and jump on a brain ApoE containing HDL. So some of the brain-produced ApoE HDLs might also be carrying ApoA1. But here's where this might really matter, Peter. ApoE gets a little more complicated, as you know. There are different isoforms. When your body manufactures ApoE, there's ApoE2, ApoE3, ApoE4. Right. Since we have two alleles, you could be a 2-2, 2-3, 3-2, 3-4, 4-3, 4-2, or 4-4. We absolutely know 4-4 is highly associated with dementia, specifically Alzheimer's disease. It's also, for other reasons, associated with very high risk for coronary vascular disease too, but that's ApoE in the plasma. In the brain, if you unfortunately inherited ApoE4, guess what? You probably have dysfunctional brain HDL particles because the E4 cannot bind or do other attributes that brain HDLs do. They can pick up amyloid and tau and carry it over and get rid of it if you have functional HDLs. But if your brain astrocyte-produced HDL is an E4, you have dysfunctional HDL, don't deliver cholesterol properly, the neuron becomes cholesterol deficient, and the neuron starts misfiring and not being able to function normally. The hope is if we would have to show this in a clinical trial, that if we could increase ApoA1 and it crossed the blood-brain barrier, that therapy might be a way to make your brain, especially if you have E4 brain HDLs, more functional. It would still be a brain E4, but it would also be carrying ApoA1, which might be able to overcome some of the deficit. So that's the hope. And the one drug that's starting to show that promise, we can't get it yet, but the CETP inhibitors have been around for a long while. And the latest one that's undergone a lot of investigation so far, with virtually everything being positive about it, is obicetrapib, which has the ability, fortunately, to significantly lower ApoB, and that's why they're really developing it. It'll be an ApoB helper drug. But because CETP inhibitors make your HDL so big, they carry extra copies of ApoA1, they can break off. Your liver starts synthesizing more ApoA1 because it thinks the body's deficient in it. And unlipidated ApoA1 can go swim through the blood-brain barrier. So wouldn't it be something if obicetrapib, as a nice little side effect of lowering ApoB, prevents dementia also? Now, this is all hypothetical, but there is some good data. They've done studies showing obicetrapib lowers beta amyloid, the various ratios of amyloid, tau biomarkers that we measure. So that is very impressive. And obviously, ultimately, you'd have to do cognitive testing on people getting that drug. But there's a little bit of a promise that there's many things that they're working on to fight dementia, but this HDL story is part of it.
Wow, it really is. That's a fantastic discussion. And what I love about being a host with you, Tom, is that I don't have to say anything. I just sit here and listen, and I learn just like everybody else does. As we begin to wind down here a little bit on our discussion, as the lipid doctor, is there something that lipidologists or clinicians who are listening into this and want to know more about, helping patients prevent cardiovascular disease, is there any one or two myths about lipids or something that you want to make sure that the audience gets correct and doesn't misunderstand? Anything like that?
Well, God, yes, the internet is full of these people who go out there and spout this stuff that they make up in their own minds because it's not supported by trials. Is that you don't have to worry about high LDL cholesterol. LDL cholesterol is needed because it's delivering cholesterol to all your cells, and cells need it. So that's myth number one. And I already told you, every cell makes all the cholesterol it needs. Very few cells need a cholesterol delivery. The ones that do are your steroidogenic tissues, and it's HDL that delivers cholesterol to them after whatever they've synthesized. So that's myth number one. The other thing I wish everybody learned, not only that ApoB ought to be part of your testing, but as much as we've talked about LP little a, the stats show that virtually an extreme minority of clinicians, even cardiologists, are even measuring it. And that's a tragedy. So that means if you run a practice, 20% of the people walking into the door are likely carrying very high levels of something that's has the potential to kill them prematurely. So why are you not measuring it? I used to get, because you can't treat it. A little joke Jamie Underberg taught me was, you tell these people, when you do a history, do you take a family history? Of course. Can you change the family history? No. Then why do you even ask about family history? So you should measure LP little a, because you and I know right now the therapy is do whatever you need lifestyle therapeutically to lower ApoB or LDL cholesterol as much as you can. Maybe one day we'll have wonderful drugs that will stop our liver from making ApoA if you have it, but that's off. One thing I didn't mention, with those studies being done, they're all being done on super high-risk people with serious coronary disease, very, very high LP a levels. So if they are successful, I'm sort of not seeing the FDA giving them primary prevention indications for the person who has very high LP a but has not yet developed atherosclerosis or aortic stenosis. And so for everybody wishing as soon as that drug is produced, I'm going on it. Only if it's off-label use and you can afford whatever they're going to charge for a new drug.
Wow, Tom, this has been such a wonderful discussion. A lot of great information you've shared with us. I know all our listeners have probably just like, oh my gosh, I really want to be a better clinical lipidologist, or I need to start being a clinical lipidologist. And hopefully you've inspired a lot of people with your discussions today. And I follow Dr. Lipid Doctor on LinkedIn, Tom Dayspring. If you need more information, he's fantastic. I do appreciate you taking the time to celebrate us on this National Lipid Day, Tom. Thank you so much for your involvement in this. I really appreciate it, my friend.
Well, this has been such a wonderful experience. I love promulgating lipids, as you know. And in my introduction, I did mention that I've met a lot of experts and mentors in my day. And I should have said Peter is one of them. We've been friends, but early on, when I was trying to learn this stuff, Peter was on a lot of those trials and publications, and met him. We always used to have great discussions when we met. So Peter is definitely one of my mentors, and I can't thank him enough. And I enjoy this little podcast 10 times more because he was the questionnaire.
I appreciate that, Tom. Thank you so much. And thank everybody for tuning in and listening to us. Have a great day.